This session is the influence of hormonal contraceptives on mental health. I'm Dr. Sanjeev Sokalingam. I'm the Chief Medical Officer and Vice President Education at CAMH. Really excited to be part of yesterday and today and the wonderful conversations I've had with many people throughout the day as well. And so excited to introduce our speakers for this session. And we'll start off with our first presenter, Dr. Inga Sundström from Uppsala University, and she will be presenting on our first presentation here. Hopefully I pronounced her name correctly. Yes, I did a good job. All right. You can ask her what her last name means, because I learned something, but I'm not going to spoil that for her. But looking forward to looking at mood problems when using hormonal contraceptives, a very important kind of clinical issue myself when I'm seeing patients on oral contraceptives. So thank you, and let's give a warm welcome to Dr. Sundström. Poromaa.
Hi, everybody, and thank you, Lisa. Thank you, womenmind, for making this come true. I mean, I've had such a great couple of days here in Toronto, in Canada. I've learned so many more new things I didn't even knew I needed to know, and I've made friends, and I'm just having a great time. And I'm also thinking that if I would ever emigrate someplace, Canada seems to be the place to go, isn't it? Yeah. Anyway, so I'm an obstetrician gynecologist by training. I just have this pathological interest in neuroscience, which is absolutely of no relevance for my clinical work. But anyway, I'm here to talk about who is at risk of developing depression when they're on hormonal contraceptives. And I wanted to frame this by presenting a patient that I met about 6 months ago. And this is a girl, 16 years of age. She came into my clinic. She was referred by the child and adolescent psychiatry to me. And the reason for that was that she had problems with impulsivity, risk-taking behavior, anxiety, drug and alcohol use, and on top of that, PTSD. She had stolen a car. She had gotten into several fights over the past months. And she was currently, of course, under evaluation for ADHD. This was her medication list, quite substantive for a girl 16 years of age. And the reason she was referred to me was that there had been some noticing that her behavior, her symptoms were accentuated during the premenstrual phase, and they wanted me to evaluate whether there was a component of premenstrual dysphoric disorder with all her other problems. But her problem, when she came into my clinic on that specific day, was none of the above. Her problem was that she had had intercourse unprotected for about a month ago, and now her menses was late. And as you understand, when you see a patient like this, everything becomes irrelevant at the threat of an unplanned pregnancy, because that will have so many repercussions for her in the future. So there was no way that I could take any medical history. The first thing we had to ensure before we went on talking was to see whether she was pregnant or not, because that would change the entire consultation. And what is she facing then? Well, of course, ultimately, she's facing the risk of having a teenage pregnancy. And this is a data set of women who have given birth in Sweden between 2007 and 2014 in Sweden. And we particularly wanted to study women with ADHD in this study because they were coming to us in greater proportions in the clinic, and we didn't know what to expect of their pregnancies. So we started a study on pregnancies in women with ADHD. And the first thing that really struck us was that among the women with ADHD we included in the study who had given birth, 15% of them had done so as teenagers. And this is in a country where we have almost eradicated teenage mothers. You can see the control group It's less than 3% who give birth before the age of 20 in Sweden. And of course, this translates to an increased risk of becoming a teenage mother if you have ADHD of 6 times increase. So the task today is to talk about who's at risk of developing depression when they're using hormonal contraceptives. The most obvious group are the really young ones. And there's a number, but these women may also have other problems, of course. And there's a long line of research showing that the risk of depression is highest in the absolutely youngest girls. Oh, something is happening here. Yeah, no, I just closed it down. This is Sweden again. These are different types of contraceptives. Depression is defined as a filled prescription of an antidepressant drug. And you can see when you're really young, the risk is much, much higher than it is once you pass the age of 18 or the age of 20, then it becomes much, much less. The problem for us when we as clinicians try to interpret these data is that the proportion of women in Sweden among all the 15-year-olds, it's just 1% of 15-year-old women in Sweden who are prescribed a contraceptive. So they're really a very selected group of young women. And for us in the clinic, it's quite clear that they are most oftenly not receiving the contraceptive because they have a contraceptive need. Instead, they receive the contraceptive as medication, most commonly because of heavy bleedings and dysmenorrhea, menstrual problems. So do we know whether this is a true relationship between the contraceptive pill and depression, or is it confounded by the indication for which they started their contraceptive or needed a contraceptive? And just to highlight this, you won't see the figures, so I'm just going to tell you what's in the table. This was just published a few weeks ago by my PhD student, Teresa Auburn, where we looked at the risk of developing endometriosis in relation to contraceptive prescription behaviors. And we could clearly see that women who were prescribed a contraceptive between the age of 12 to 14 were at 4 times increased risk of being diagnosed with endometriosis later on. So this is a very select group of women. And again, even though you wait until you're 15 or 16, which is, again, relatively young in Sweden for contraceptive use, your risk of being diagnosed later with endometriosis is almost twice as high than for women who don't need contraceptives. So it's a special group. The other thing I wanted to say, which I think is important today, is that contraceptive use is rarely a problem in really mentally healthy women. But the problem is in women who either have a past history of mental health problems or ongoing mental health problems, just like my patient. And the data I'm going to show to support this is based on 2 randomized placebo-controlled trials that we have done. I prefer the randomized controlled trials because I simply find the evidence so much stronger than the epidemiology. And the first one was a proof of concept study, really actually showing where we wanted to demonstrate that hormonal contraceptives may have detrimental effects on mood, because that was not really known at the time. And this was actually also the first study that was done in young women. Previous studies had been done in women who had undergone sterilization, meaning much, much older women. We included women who came to us stating that they had a past problem with mood when they had been on the pill previously. So again, a very selective group. And we gave them the worst possible pill we could think of, namely the ethinyl estradiol levonorgestrel pill. And this is just not just my opinion. There's a good amount of evidence to suggest that this is probably the most mood-provoking pill we have on the market. It's also the gold standard pill. It's also the pill that you're most likely to be prescribed the first time you ever get a contraceptive prescription. The second study, for that, we decided to use an estradiol-based pill, which I think is not available here in Canada. I know it's absolutely not available in the US. It's a much milder pill. And the second study, we targeted like normal users. What we did not do was that we did not exclude any women with previous or ongoing mental health problems, but we kept track of them by running psychiatric interviews and asking detailed questions about their past mental health history, so we knew who they were. And we asked them to keep daily diaries of their mood symptoms. And this is important because having a mental health problem is an exclusion criteria for any of the clinical trials that have been conducted in development of hormonal contraceptives since the 1960s and up until now. So we have no information about what would be a suitable contraceptive for anyone with a prior mental health problem. Again, this is the first study, the proof of concept study with the levonorgestrel pill. We just treated them for a month, and we were able to reinstate symptoms of depression, mood swings, fatigue, and some somatic symptoms just after 3 weeks of treatment. Not surprisingly, though. But look at their depression ratings. They did increase significantly during treatment with the pill, but it was really a very mild depression. It's not in the clinical range, but absolutely noticeable for the young women, of course. The second study, we took the opportunity to be a little bit more detailed. So we looked at the different phases of the treatment cycles and the baseline cycle and compared the difference between the two. We wanted to examine the menstrual phase, which is essentially the pill-free interval, because there had been reports suggesting that this phase was the one associated with like the most mood symptoms. And of course, we wanted to assess the premenstrual phase because there are studies showing that contraceptives can be beneficial for women with premenstrual dysphoric disorder. And then for the rest of the cycle, we just termed it intermenstrual phase, but it was actually the largest of the phases that we studied. And in healthy women, what we found again was that they had increased ratings of anxiety, mood swings, and irritability in the intermenstrual phase. But what we also found was that they had a premenstrual improvement in depression, which is kind of in line with the literature on contraceptives used for premenstrual dysphoric disorder. One important feature, though, is that look at the difference between baseline and the treatment cycle. It's really, really tiny, tiny. So it's in the range of 0.2 to 0.3 scale steps on a scale that runs from 1 to 6. And you could even argue, is this clinically relevant? I would say yes, it is, because the reason why the mean difference is so small is because the individual response to hormonal contraceptives is so variable. This is what it looks like when you run a placebo-controlled or a contraceptive study. This is capturing all mood symptoms across the entire treatment cycle and looking at how many improved and by how much they improved, or how many got worse during the study. And as you can see, the darker blue bars, which represent placebo, are slightly higher on the improvement side, and the light blue bars representing the pill are slightly higher on the mood worsening side, meaning that this whole distribution is actually significantly different between placebo and the pill we're using. But again, I mean, if you're at the far end with a more than 40% increase in mood symptoms, and you start from something that wasn't really so good at baseline, that could potentially tip you into clinical depression. Also notice that placebo was not good either. Just being part of a study actually made women feel worse. I'm not sure how to interpret that. Another feature, remember the placebo users, they were exposed to their own normal natural menstrual cycles. You can see the expected increase in their mood symptoms between the intermenstrual phase, where they presumably are in their follicular phase, and the luteal phase, where their symptoms increase. And you can see that the differences we had were driven by the changes in the intermenstrual phase. And we interpret this as being caused by the progestogens, most likely, that they are being exposed to when the controls or the placebo users are in the progesterone-free follicular phase. We then went on to see what the results looked like in the women who had a prior or ongoing mental health problem. So the groups were stratified based on the psychiatric interviews that we did at baseline. And we could actually see and demonstrate that the results of the entire trial were more or less driven by the women who came to us with a past or ongoing mental health problem, whether it was anxiety, depression, a previous eating disorder. These were the most common diagnoses that we encountered. Whereas if you look at the healthy group, there was almost no difference at all, except for a little more anxiety. But if you look at the small differences in the healthy women between the two treatments, and you also look at the p-values, you realize it's not a power issue. If I were to design a study proving that the pill is worse than placebo in healthy women, I would have to have a sample size of several thousand to show that this small difference would be significant. So what are we going to do with your patients then? Well, again, it's a problem. We don't know. They've not been included in any trials except mine. And we just tested one pill, which apparently was not beneficial for them. We have some data from epidemiology, again, coming back to the young girls with ADHD, which we see quite a lot of in our clinics nowadays. And again, we made use of the Swedish registers where we have prescription for contraceptives. And again, we used filed prescription for an antidepressant drug as our outcome, being depression. Although I understand that, of course, these drugs can be used for anxiety or PTSD or a range of different disorders. And so what we did in this study was that we compared the risk of developing depression between women with ADHD and controls, but also across a number of different types of hormonal contraceptives. And what we found were two interactions between contraceptive use and ADHD. And those were for the combined pill and the progestogen-only pill. Whereas the risk of developing depression if you are on the patch, the vaginal ring, the implant, or the hormonal IUD was similar in women with ADHD and the controls. And the risk estimates in Sweden are pretty low, I should say, in comparison to other studies. So about 20% increased risk if you're on the implant, 40% increased risk if you're on the hormonal IUD. But what is happening with the pills? So we had to go on and evaluate these interactions. And this is a busy table. I'm just telling you that, of course, having ADHD increases your risk of depression by 3.8 times. If you add a pill on top of that, it increases to 5.2 times. Pretty high hazard ratios to demonstrate, I should say. And the same phenomena with the progesterone-only pill. And if you want to see how this plays out graphically, the two top lines are the healthy women. Actually, in this cohort, we see lower risk of depression in the women in Sweden who were prescribed a combined contraceptive and did not have ADHD. Whereas you can see the two bottom line are the women with ADHD who are not on the pill, and the bottom line, the ones who are on the pill. And how do we interpret this? Well, clearly, this does not seem to have anything to do with the hormones that are in these different types of contraceptives. We just think that it has to do with the fact that the pill is more troubling for women with ADHD. It's another thing they need to remember on a daily basis. And if you forget a pill, you end up having lots of problems that may cause irregular bleedings, that may cause you to worry about whether it's safe enough if you skipped a few days. And it may also lead to unplanned pregnancies if you're not keeping up the daily routine. So we simply think or interpret this that having a contraceptive that you don't have to think about on a daily basis, like an implant or an IUD, makes life easier if you're suffering from ADHD. So to wrap this up, I think we need contraceptive precision medicine. This is something that we don't have right now. It's trial and error. That's what we call it in OBGYN. We do see many women suffering from or experiencing worsening of mood when they're on any type of contraceptive. It's not just the combined pill, it's all types of contraceptives. Clearly, we need more research to give better advice to the women who are most likely and most vulnerable to experience depression when they're using contraceptives. And when we see the individual patients, we need to think about things like, are you on the right progesterone, for instance? Are you on a pill with levonorgestrel? Maybe change to a pill that contains an anti-androgenic progesterone. They seem to do better. Are you having too much estrogen? I would argue that ethinyl estradiol is a pretty heavy dose of estrogen, especially to the young women. So for some, it might be just too much estrogen for them. Or it could be too little estrogen. If you're on an implant and you're sensitive to the progesterone, that could lead to inhibition of follicular growth and thus inhibition of your own endogenous estradiol production when you're using the implant in certain women. The only thing I want you to remember from today is don't advise your patients to stop taking their contraceptives when they have mood problems. That may place them at a far greater risk of much more adverse outcomes. Instead, what you do is advise them to change to a different type and make sure you make intelligent choices so that you provide them with something that's different from what they are on. Yeah, and implants for women with ADHD. And if you have something that you want to publish, please check this out. There's a themed issue in British Journal of Psychiatry. It's edited by Erica Comasco, Neil Epperson, and Jayashi Kulkarni in Australia. And it's themed Psychiatric Symptoms on the Ovarian Hormone Roller Coaster with a deadline in late September. So please check that out and submit. There must be tons of potential manuscripts in this room, I'm sure. Thank you.
We have time for one question. One question. See a hand over there.
Thank you for your wonderful talk. I wanted to ask about your interpretation of the ADHD study. And first, if you corrected for missed pills, as you mentioned, that may be a difference. Okay.
No.
And then also, if my understanding of your interpretation was that it was about taking it consistently. And one of the things I was wondering is there maybe an alternative mechanistic understanding that an IUD or an implant may not be going through the gut or circulating, thinking of an IUD, it's more local. Is that a possibility of mechanism why OC may be different than the other methods?
It's absolutely a possibility. Absolutely. Very brilliant of you to spot that. Yeah, it is. But again, I mean, these are registered base data. So it's on the population level. So we don't have the detailed information on when and why and if they miss a pill. Maybe they don't miss one single pill. What do I know? Yeah.
Great. Thank you so much, Dr. Sundström, Poromaa. Great presentation. We'll continue with our next presenter. So it's my pleasure to introduce Dr. Birgit Derntl, who's from the University of Tübingen, and will be presenting on how you feel under hormonal contraception, building on our last presentations.
Thank you so much, dear Lisa, dear everybody actually here. It's been a pleasure to be here. It's actually an honor. It's kind of being in the bubble of everybody who has the same ideas or similar ideas, same thoughts. It's really empowering. So I think this is a moment, a movement, and particularly from the European side, it's wonderful to get to know you and to also kind of see that we can collaborate globally a little bit more. So that would be super. It's actually a hard task for me now to fit in between Inga and Wiebe as next and to squeeze in and show two small studies that we did on hormonal contraception and then show a little bit else what's going on in Tübingen. So hormonal contraception is beautifully alluded to by Inga. We do have different forms of that, but I guess first, let's see, there are almost 1 billion of women worldwide using a contraceptive method. And it could be hormonal, it can be non-hormonal. But for the hormonals, it's the oral contraceptives, as Inga was talking about, and it's also the intrauterine devices. And of course, then I'm now talking about the hormonal intrauterine device, which includes levonorgestrel as the progestin. So these are actually the two types of hormonal contraceptives I'm going to talk about in the next 20 minutes. So when we started with IUD, and here the LNG IUD, Zoe Birger, a PhD candidate in her senior year, hopefully, and me, we actually wanted to screen the literature. What do we know about IUDs in terms of mental health? And we did a systematic review published in Finn and looked into mental health. Well, I can tell you inconsistent data. It's just a few studies actually that looked into mental health in IUD users. Some show improvement, some actually show a decrease in mental health. What in terms of quality of life, there is an improvement, particularly in those who have gynecological issues like heavy menstrual bleeding. In terms of sexual functioning, also, again, very few studies, but what they show more or less is if you have a problem like menorrhagia, heavy menstrual bleeding, you receive the IUD, it seems to improve your sexual functioning. Now, the other two topics, of course, were also interesting to us. At the time we did this systematic review, there was no study published on brain. So we don't know what the IUD actually does on brain structure and brain function. But to be clear, since 2021, 3 years have passed, 2 studies have been published by now, one by Adrian Belz, looking into brain function, and another study which we did with a Lithuanian collaborator on event-related potentials and emotion regulation. So there is a lot of space for research in this area. But I show you the other topic, and I'm so happy to speak now because stress was introduced by many wonderful colleagues to you. So I don't actually need to elucidate the stress and the HBA axis and so forth, but I can just dive into stress and stress reactivity and show you the result of the only one published study that we have up to now on hormonal IUDs in women. So what our Dutch colleagues actually showed in 2017 was that in the hormonal IUD group, which you have here in red, you also have a copper IUD, you have an OC group, and you have the natural recycling women, you see a potentiated cortisol reactivity to the triasocial stress test, as we also heard in the morning by Dr. Chester. And you also see a potentiated heart rate in the IUD group. Of course, it could be a concern, what is happening to the stress reactivity in that group of women taking that hormonal contraceptive. But what we also have to acknowledge that in this publication, there was actually no information on the endogenous and exogenous hormone levels. There was no information on the subjective stress level, and there was also no information on the duration. And I'll later also give you another information that was given in that study and which actually made it different to ours. So that is something where we said we have to do something. We need to run a study. Maybe we can replicate, maybe we find something else. So that's the study Zoe actually did for her PhD, where we had a within subject controlled design So every woman coming to our lab did the Maastricht acute stress test. That is a physiological stressor, ice cold water, and mental arithmetics, achievement stressor. So we had the cognitive and the physiological stress combined. And all of them actually also underwent a placebo condition where they had lukewarm water and they just had to count from 1 to 25. And we collected saliva to analyze cortisol. We collected blood to analyze the sex hormones. And we also looked into physiological response. And we also had a daily diary for 1 week where they actually told us about their mood. So what about the hormones? Well, that's the group size you see here. So 27 women in the naturally cycling group in the mid-luteal phase. We have 33 in the OC group, and we have 29 using the IUD. And in terms of hormones, it's actually that what you would expect. What's happening that in the OC group, you have the suppressed estradiol levels, endogenous estradiol levels, I have to say, and you also have very low endogenous progesterone levels, which is also true for the IUD because here you have the progestin that's working. You see also an elevated cortisol in the OC group, which is also known and has been shown by others before. But what is shown here for the first time is actually the levels of levonorgestrel that we also have in our groups. And what you can see is that the OC group shows significantly higher levonorgestrel levels than the IUD group. Also could have been expected. In terms of the stress reactivity, you do see a group by time interaction in terms of subjective stress. So our stress induction worked, at least on a subjective stress level. Here in the stress, they said there's something going on post-stress. They actually felt stressed, not after the control condition. And you also see that there is a significant difference between the IUD and the naturally cycling group. In terms of cortisol, and that of course was one of the major interests of our study, given that we knew there could be a potentiated cortisol reactivity in the IUD group, we actually do not see a difference between the IUD and the naturally cycling women, but we have again a blunted cortisol reactivity in the OC group, which is also known and has been shown before. So we could not replicate the finding by the Dutch colleagues with the potentiated cortisol reactivity to stress. So to sum up this study, I think what we have to consider is that hormonal contraception affects stress parameters in different ways. So we saw that the subjective stress reactivity was actually higher in the women using the IUD, and they also reported more negative affect in the daily mood diaries. I didn't show you that data. And so the question is there an increased sensitivity to negative mood or to stress? And we could not see the cortisol reactivity, which of course would be in line with such an assumption. But I think what we have to also see is the cortisol reactivity, and I know that Vive may be pointing to that. In the study by the Dutch colleagues, they only included women using the Mirena, and the Mirena has the highest level of levonorgestrel. In our study, we only had one woman using the Mirena, and all the others had the other two types of IUDs, which have way lower levels of levonorgestrel that they are exerting to the body. So there might be that this is an interaction between cortisol and actually the level of progestin that is released. So I think we need more research into that direction, because what it tells us is that not every IUD is, also not all IUDs are the same. And I think we need to also look into this. What is it doing? Heart rate that was elevated in OC, which is yeah, we have to discuss what is it, because the literature on heart rate in OC and stress is inconsistent. So there are some that show elevated heart rate. There are some that do not show elevated heart rate. So what is going on here? We have to dig deeper. And skin conductance did not show a group difference. And I think what I want to summarize here is that if we are interested in stress, we have several parameters, and stress is multifaceted. So we should kind of address all of these parameters to get to a profile of a stress reactivity in women. And what's still to come, we actually did the stress induction in all women 3 to 5 months later again. and also did the daily diaries. And that's what so it's just analyzing is how does that affect actually the stress reactivity if you ask your participants to come back and do the stress test again. Now, stress is a transdiagnostic factor, and we have heard that in the morning. I now want to talk about another factor that is actually showing an impairment in many patients with mental disorders, and is kind of an interesting factor to investigate, empathy, because this is really now complex social cognition that we are interested in. And you have heard Ann-Christine, hopefully, yesterday talking about her study. This is part of her study where we also had a functional task looking into empathy and empathy behavior in the brain. Now, how do you measure empathy? There may be different options, and there is a lot of discussion what is empathy. But for our task and for this study, we kind of used and developed a new task where we say, okay, that could actually measure what we want. Imagine yourself in a situation, you go on a concert of your favorite artist. How would you feel in this situation? This is our self condition, because empathy is a lot about self and how I feel and how would I feel for another person. So this the self-other distinction that we are interested in. But first we should ask, how is a person actually responding to a certain situation? And then we can see, okay, and how does this person respond if a friend, a stranger, an enemy is going through that same situation? And that's what we did. We had the other condition where we also said, well, imagine your friend or stranger or enemy, you could place anything here, goes on the concert of her favorite artist. How does she feel? What do you think? How does she feel? And with that, we are actually going into cognitive empathy perspective taking, or affective theory of mind. And if I then ask you, and how do you feel now knowing that your friend is in this situation? That would be affective empathy. And I think it's really essential to also divide those two, to also get clearer about our empathy deficits that we so often see in our patients with mental disorders, to better understand how can we actually help them. Now, Ann-Christine studied healthy women. They were taking oral contraceptives. They were naturally cycling, a group of them, during the early follicular phase, so when the endogenous hormones are low. And we also had a group during ovulation, when estradiol is high, when it's actually our hypothesis that we are most social, we are most actually outgoing, and there was also some indication that that might actually affect our empathy. Well, what we saw in the behavioral data is, and here's the cognitive empathy, here you have the affective empathy. And what you see in the condition self versus friend, here in light blue, is that the OC group shows a reduced rating for the cognitive empathy in comparison to ovulation, but also in the affective empathy in comparison to ovulation group. But what is happening in the brain? And here, we have group differences, and group differences are of course interesting because they tap into areas that we knew by a meta-analysis that they actually are responsive to empathy. The dorsomedial prefrontal gyrus being a major hub for affective empathy, while the temporoparietal junction is a major hub for cognitive empathy. And actually in both of these areas, we do see a group difference in terms that the OC group shows reduced activation or reduced bold signal in comparison to the ovulation group in both areas. And I think what's now nice is to link the behavior with the brain, but what we should also look into is the hormones. And this is the first time that actually an fMRI study looked into an association between ethinyl estradiol, so the exogenous estradiol, and bold signal. And what Ann-Christine reported was a significant association. So the more ethinyl estradiol we had in the blood, the lower the activation in this region here in the dorsomedial prefrontal gyrus. So this is, of course, interesting. And it also is a nice picture to paint. But I think we have to be careful It's associations that we are doing here. There's no causal relation here. I cannot say that OC women, because of taking OCs, are now showing reduced empathy. They may have had reduced empathy before. It may also be other factors that come to play here. So I think we have to be very careful in how we interpret this. But what it does is it gives us an option, and it shows us that we actually have to look also into the exogenous hormones and how they affect the brain and behavior. Because up to now, we mostly looked into the endogenous levels, and I don't think that they show us the true picture in women taking oral contraceptives or using hormonal contraception in general. And I mean, being fortunate and having Ann-Christine here, actually, she did the longitudinal study. Those of you who have listened to her yesterday will know. So please go to her poster and ask her what is happening to empathy in those that start with the oral contraceptive or stop it. And if you want to go further, you could also ask her about psychosexual health, because this we were also assessing before and after. And I didn't include her because I think she should present those results. Now, thank you. Now, I was just presenting you 2 studies on cycle contraception. And I think based on what we have heard before and what we will also hear, I think in the afternoon, it's not enough to just go for one of these phases. We actually have to look at the whole reproductive life, at the whole lifespan in general, but definitely into the whole reproductive lifespan, because they are characterized by different hormonal profiles. They all affect our brain structure and function. And I think what we want to know is, are there any effects that come up here? Like we had several studies on stress and puberty. And what does that mean later in pregnancy? And what does that mean later in perimenopause? And I know that Wiebe will present some of those studies. And I mean, we're also trying to do that. And it was also alluded to that there is a gender gap in the prevalence rates of mental disorders. And it starts with puberty and it stays up during the whole reproductive lifespan. So there is something going on with women, and there might also be an effect of the hormones here. And you do see here the prevalence rates of Germany and Sweden. And there's a reason why this is Sweden, and you will understand in just a minute. Because it's a global problem that we are facing. I think we've been shown this also by the wonderful presentations here, and it has been under-investigated. It's actually also a problem of a training, because we need interdisciplinary training. It's not enough that I, as a psychologist, psychotherapist, know about this. We need to get together. We need to have psychiatrists. We need to have neuroscientists. We need to have the gynecologists, obstetricians in the room. We need to have public health. We need to, you name it, the informatics, all of them need to get together. And I think we need to come up with a training module. How can we train those diverse people actually in women's mental health? And for that, it's always good to have a strong partner and an international partner. And in Tübingen, that was what we did. And we found them, of course, in Uppsala University with Wumha and Inga, of course. And so it's kind of wonderful, and we dared to dream and dared to do something together that could kind of have such a translational element in it. And we applied for an international research training group, the IITG, on women's mental health across the reproductive years. And actually, the German Research Foundation is funding this now since last year, and it's still ongoing until 2027 and will be up for renewal then and have another 4 years of funding, hopefully. But what it does is it combines researchers from Uppsala and from Tübingen. And you see here, for those who did not know where Tübingen is, where the heck is that? It's here, southwestern of Germany. Here's Uppsala. And those universities are actually sister universities funded in the same year. That's why we are in several of the networks. But I think it's also wonderful if there are great collaboration possibilities coming up. And here you have 11 PIs from each side, with Inga and me being the spokesperson. But you probably also noticed there's another face here that you know. Because we have Mercator Fellows. And we're so happy to have Lisa as one of the Mercator Fellows. And I'm Christine, probably another. She's the postdoc of the IRTG. So what do we do in the IRTG? We have right now 12 PhD students, and that's just the first cohort. There will be a second cohort of another 12 PhD students. They all do research in the area of women's mental health. And here I just put down what are the areas that we are investigating right now. There is one area of stress, because this is transdiagnostic, and we have projects on epigenetics and puberty, estradiol administration, hormonal contraception, and how that changes your stress reactivity, depression versus premenstrual dysphoric disorder, and also maternal and fetal health. We have positive valence and reward on the other side, because you need to look at both sides. Many mental disorders are actually characterized by a reduction in positive mood and not only an increase in negative mood. So let's understand the positive mood as well, reward. And here we look into dopamine and the menstrual cycle in reward, oxytocin and the menstrual cycle, psychosexual health across the perimenopausal transition, anti-estrogenic therapy, so a therapy that we use in breast cancer patients, the effects of that therapy on brain function and structure, and also psychosexual health, and social media and puberty. And we have two projects that actually link the data that we get here, because they look into gender norms and they also look into genetic data. And what the beauty is of all of this is all of these use the same task. All of these use the same task. So we will pool data, and we will pool data and get data across the full reproductive lifespan. And Christine also showed science communication. I think science communication is very important in the area of women's mental health. We need to translate our findings to the public, but we also need their voices back here. And I think we had a wonderful symposium yesterday. So we have the podcast that is organized by our PhD candidates. So it's not the PIs, it's actually the doctoral researchers who are doing this, who are reaching out to speak to experts in the field. And Vive, your podcast is up today. So yeah, if you want to listen in to Vive and others, please do that. And just, I know I'm running out of time, but I thought it's wonderful what you have built up here with the Women Mind in Canada. We're also trying to get somewhere near that, hopefully, with European initiatives. And we just had a Lawrence workshop end of February, where over 40 participants got together, and we were talking about and exchanging, brainstorming about hormonal fluctuations across the female lifespan. We also came up with a new association, Flame. You can follow us on LinkedIn, and you can actually also watch a video on what PhD candidates say, being part of this association, also being part of that workshop that we had. And what we hope is that we'll come up with such a recommendation paper as another Lawrence workshop where Lisa and Claudia were also taking part, because I think it's much needed that we inform us and that we inform our colleagues about recommendations. How can we investigate women's mental health? And you are the experts here, so we need to put that together and get it out. And then hopefully, as we did with your recommendations, there can be comments by you and by others actually adding aspects to that that we did not cover enough, or that kind of will broaden again our view. And with that, I'd like to say thank you. Thank you for being here. Thanks to colleagues.
Right. Thank you, Dr. Derntl, for a great presentation. We have time for one question. And I'm sure more in the discussion period as well. That can happen. Anyone, any questions? Lisa.
This is an unfair question, but I'm going to ask it anyway. How can this be the first time that people have looked at ethinyl estradiol and bold signal? Seriously? Is that what you said? Is that what I heard you say?
Yeah, it's not the first study that actually analyzed ethinyl estradiol, but it's the first fMRI study that looked into ethinyl estradiol. And I think for the longest time, it was kind of, okay, we cannot really detect it, and why should we? But I think looking at the levels of the endogenous levels of estradiol and progesterone that are suppressed, and the high levels of exogenous hormones, and we know that they are very potent actually in the brain and how they work. So I think this is something that we really need to uncover what's going on here.
Yeah, I think that just to underscore that, I think that's so important because so many people pay attention to the endogenous hormones and say they're low, but actually exogenously they're
Yeah.
super
Yeah.
high. And we just heard talks about that. Thank you.
Right, thank you. And thank you again, Dr. Derntl. It's my pleasure now to introduce our next speaker, Dr. Viva Frokjaer. And Dr. Frokjaer is going to be speaking on hormonal contraception and depression, again, looking at precision psychiatry. All right.
Thank you so much. So I'd like to start with thanking womenmind for creating such a curious, generous, and supportive environment and atmosphere here for us at this conference. I really highly appreciate it. And I think this group spirit is special to our scientific community and very important and critical for how we can move forward. So thank you everyone for participating in that group spirit. I'll share today a series of recent studies of hormonal contraceptive use as a model for hormonal contributions to depressive episodes in women, and we'll discuss the implications. These are my disclosures. So what I will cover is a bit of context, then first a study on molecular serotonergic brain signatures of combined oral contraceptive use, then two studies leveraging data from the National Health Registers in Denmark, one on hormonal contraceptive intrauterine system use and depression risk, and one kind of proof of concept study where we took advantage of the registers to see if we could find signs of hormone sensitivity to translate across reproductive life, and three, discuss the implications for precision psychiatry. So as we know, very many women use hormonal contraceptives, and we need to carefully weigh positive and potential negative effects of the use, and also provide the research that can support such weighing. So we know that combined oral contraceptives work by suppressing the HPT axis, so really suppressing ovarian endogenous hormone production, adding back synthetic hormones that do not share the same properties as the endogenous hormones, but then help us to prevent unintended and unwanted pregnancies because disrupting ovulation and also creating a change in intrauterine environment. So this is just an illustration of that, and I'm sure you all are aware of these mechanisms. So it's important for me to stress that we cannot underestimate, when dealing with this topic, the importance of birth control tools for human emancipation and a free world. So this is important in a historical perspective, but also today it's clear that reproductive rights for women are under pressure. Here illustrated with an example from the Women Life Freedom movement in Iran, but also very clear, much closer right now to us, is the political climate around reproductive rights in the US. So this means that we have to study, criticize with care and in a nuanced manner, that I think Inga also very nicely alluded to. And I'll argue that includes to study potential side effects as well as individual variability in a spectrum where we embrace women who are doing better on oral contraceptives compared to on their natural cycle, to pill tolerators or healthy users, but also embracing women who experience subclinical depressive symptoms with the use and even severe depressive episodes. So maybe we can think of this as a second wave of emancipation, that we are able to study now how to best use hormonal contraceptives because the women before us have paved the way. So indeed, some women do develop depressive episodes after starting hormonal contraceptives, and Inga also alluded to this type of data from the registers. So the risk for getting prescribed an antidepressant or get a diagnosis of depression peaks within 3 to 6 months after starting a hormonal contraceptive. And this is replicated, at least partly, in different register sources. What is interesting is that this phenomena is strongest for the adolescent group, as Inge also showed us, and also translate across all types of hormonal contraceptives, even though it might be hard to believe that, for instance, so-called locally working hormonal IUDs also carry this risk, and we should be aware of potential confounding factors, as Inge also pointed out, but also be curious to these phenomena, I would say. So my group really wanted to contribute to understanding and kind of work from epidemiology to neurobiology and try to ask what might explain that some women tolerate oral contraceptive less well and develop depressive symptoms, and whether this matter for precision prevention and treatment of depressive episodes. And surely I don't have all the answers, but I'll show you a little bit here on the beginning. So first we wanted to ask, does oral hormonal contraceptive distort depression-related brain architecture? And it's because we had an opportunity to do this first step, since we have the world's largest database, which is a shared database for you to know, on molecular brain imaging at population level, and healthy users are also included. And we could find 17 combined oral contraceptive users who had a relevant measure of serotonergic brain biology, and we could compare them to 37 non-users, healthy cycling women. And the factor we compared, or the phenomena we compared, was the serotonin 4 receptor distribution or availability in the brain. So this is an interesting receptor since it sits in high densities in key regions for depression pathophysiology in the brain, striatum, hippocampus, etc. Also, strong rodent evidence points to anxiety-like and antidepressant-like effects of stimulating the receptor. And human data points to pro-cognitive effects. So cognitive dysfunction, as you know, is important both in depressed states, but also in so-called remitted states. So this again points to actually this receptor as also a potential interesting target, and interesting in the context of both sex hormones and depression risk. So what we saw when comparing our two groups in this cross-sectional design was clearly a marked reduction in 5-HT4 receptor binding in the panel here with the combined oral contraceptive users, which you may see as a slightly more pale coloring of those two slices of the brain. So this is an average image of the group. So in numbers, this compares to quite a marked difference of 9 to 12% in binding. And what is very fascinating about this, I think, is that these women were perfectly healthy, right? At least as how well we could screen them. So it also attests to the female human brain being able to buffer quite extreme physiological states without tilting into a depressed state. But what if then other risk factors comes on board? Maybe you have ADHD, maybe there are other stressors, it might matter still. So after seeing that, we also worked with another cohort of unmedicated patients with major depressive disorder. And we noticed that compared to the gray group, which are healthies, all the colored dots are patients with major depressive disorder unmedicated. They also are low in their serotonin 4 receptor setting. So this is actually some first evidence of some serotonergic differences between depression and healthy states. And we split them up with regard to how well they responded to an SSRI. So what you can see is the part of the group that were lying lowest in serotonin 4 receptor levels were also the one that responded best to a certain serotonergic acting drug, which might make sense. So, but what if we place the healthy oral contraceptive users in this picture or try to do it? We could say, well, there are some parallels to the healthy also users. They're also low in 5-HT4 receptor binding. And we really think and are very curious to ask questions about whether this matters for the efficacy or optimization of both prevention and also antidepressant strategies. So it may be that this reproductive context matters for how we can mobilize and rescue depressed states by trying to target the serotonin system. We don't know of these things, and we just got funding now to work in that direction. So I'll be able to tell you in a few years' time. But in the women, particular from this, in the women from this sample, unmedicated, as you know, we did not see a change in their serotonin 4 receptor binding in the depressed state with whether they used or did not use combined oral contraceptives. So they split it up quite nicely, half and half. But we did see that their kind of depressed level of 5-HT4 receptor binding in a key region of the reward system, the striatum, was mapping onto anhedonia features here indexed as sexual interest. So this is also interesting to us because it might mean that serotonin 4 receptor settings are also important for especially female depressed states and maybe also sexual health or maybe even broader anhedonic features and maybe even transdiagnostically. We also don't know this yet. We also worked with cortisol dynamics, as Birgit very nicely alluded to, and that we'd also treated in sessions yesterday. So also I don't need much introduction, but we work with something called the cortisol awakening response. It's not actually a stress response. It's more, we think about it as a stimulated HPA axis output index, and it has some similar features to stress responses. So we can capture it with home sample of serial saliva from awakening until 1 hour after awakening. So it's kind of a burst of cortisol that we receive for physiological reasons in the beginning of the day. And what we clearly saw with combined oral contraceptive users, again from the SIMBI database, was a blunting of these cortisol dynamics. In the blue line there is the combined oral contraceptive users. We also saw a slightly higher level of cortisol, but they're also more flat, right? And we think, it's important to be able to shift gear and mobilize extra capacities, both physiologically and also cognitively, when faced with daily stressors and also more extreme stressors. So remember, these women were healthy. So again, they're able to buffer this different situation of their capacity for mounting a cortisol response. But it may be if other stressors comes on board, or in adolescence, maybe it might be more important. Yeah, so that's really also a very important question to us, and I'm very happy that the next speaker is exactly focusing on this. I'm looking very much forward to that talk. So we need also to ask about, does it matter when you start hormonal contraceptives in terms of the effects on brain and potential effects of mental health? There's a little bit of data pointing in the direction that there may be more blunted stress responses in teenage girls who's on oral contraceptives compared to adulthood. But we need to do more in this direction, I would say. So now for the National Health Register studies, first for the hormonal intrauterine system study. I need to say this is work still embargoed from the journal that is going to publish it, so I'll have to ask you not to post this, but I was allowed to share it, and I would very much like to share it, but I'm just trying to remember to say this now before showing you the data. So here we really wanted to ask and focus on hormonal IUD users only. So within that group, we are able to, in our registers, to find 3 different dosages because there are 3 different dosages on the market right now. So we were looking and getting a population of first-time users from the Danish National Health Registers, and we could identify users in different groups with different dosages. And we could then pick signals of or indexes of whether they developed a depressive, something that appeared to be a depressive episode as a prescription of an antidepressant or a diagnosis in our systems within 12 months from starting. So, so what was clear was that we actually saw the expected rank order of the risk for developing a depressive episode with a dose-dependent pattern as illustrated here as a survival curve. So you have the lowest dose in green, then orange, and then the violet. So what we also should appreciate is that it's not large absolute risks. So that's shown out here in numbers of 1,000 women, but of course also acknowledging that this is a tip of the iceberg phenomena. So there will be also women who go untreated or with subclinical symptoms that we do not pick up in the registers. But I think still is good news. We're not talking about really huge absolute risks, but we're looking maybe into getting more curious about the mechanisms that Birgit also really much alluded to. So I think this is the kind of inspiration we can get from this type of data. So now for the proof of concept of whether sensitivity to develop depressive episodes in hormonal shifts translate across reproductive life. Again, we took advantage of the Danish National Health Registers, and because of the span they're covering, what we could identify was kind of two representatives of these events. One was depressive episodes with an onset closely related to starting a hormonal contraceptive. So that was one exogenous hormone shift, maybe you could say. And then postpartum depression and even perinatal depression. So what we asked here was whether women who have had a history of a hormone contraceptive associated depression also had a higher risk of developing a later postpartum depression as compared to women who had had some other type of depressive episode. So it's risk on top of the risk coming from just having had some depressive history or depressive episode history. And we were able to pick that up. And I think that was quite surprising, actually, and quite interesting. So that's seen here as the difference between this bar. This is the hormone-sensitive one, and the reference with some other type of depression. Also, what is clear is that what is most protective is to not having had any history. So that's, yeah, unsurprising. So this actually kind of supports that we may be able to think of hormone sensitivity as something that translates across reproductive life. Benicio Frey also showed this really nicely yesterday, or alluded to it with the example of PMDD and postpartum depression. So now, does reproductive context matter for novel antidepressant strategies? I would say yes, and I'm sure I can agree with many of you. But we can maybe just look a little bit on this list. So I would say that it is an interesting question whether tapering off hormonal contraceptives in some depressed states, maybe in treatment-resistant depressed patients, might help us to optimize antidepressant strategies. At least I think it's important to study. I've shown that serotonin 4 receptor agonism as a target might be important, particularly for women with depressive episodes, maybe also other diagnoses, sexual health factors, and maybe also the reproductive state matters. We know of allopregnanolone analogs that directly target the hormone-related mechanisms, estradiol augmented treatments, but also psychedelics, I think, would be important to study in the context of different reproductive contexts. It also targets the serotonin system, namely the serotonin 2A, and we have a lot of hope and also should be careful to be able to use these compounds in a precision psychiatry perspective. So for concluding and summing up, I've shown you that use of oral contraceptives is associated with depression-related brain architecture. In a cross-sectional setting, we are following that up in a longitudinal study, and we can share that within the next half year. We almost have the whole sample. I've also shown you that hormonal intrauterine systems are associated with depression in a dose-dependent manner, and provided some evidence that we may think of hormonal shift sensitivity associated risk to translate across reproductive age span. And I think this points to several important perspectives. One is, can we move this forward to be able to inform individualized contraceptive counseling, study more of how we can, provide pragmatic precision psychiatry, right? If we were just able to take in a clever way into account reproductive context, it would probably matter for both existing and novel antidepressant treatments. And then addressing the question whether if it matters when oral contraceptives are initiated, if it matters if you start in adolescence versus adulthood, but maybe also if you start early postpartum, right? That's another opening window in the female brain, and it's a place where all of us would want to have access to safe hormonal contraceptives. So yeah, that's the type of work I'd like to be able to talk to you about next time. And many people to thank, very much my research group, a great leader in our research group called Gitte Moos-Knudsen, who provides such an inspiring environment for us to thrive in. Dear colleagues, many of you here who are kind enough to collaborate and help us study these things. And thank you for your attention.
So great. Thank you again for a great presentation, and we'll open it up for some questions for Dr. Frokjaer. Scanning here. And go ahead, Lisa. Of course.
You know, I can get really chatty. So do you think, I really love your idea of emancipation with precision medicine. I have found it to be a term that the medical community doesn't think about in terms of sex or female sort of specific variables, which is a little bit perplexing. Like I think that your work there looking at hormonal sensitivities to oral contraceptive antidepressant use, and then later on perinatal depression is really, really interesting. And what a great barometer that could be, a sort of predictor for, you know, not again that anyone's going to stop becoming pregnant, but that maybe this would be something that would be very useful for the person to know and understand.
Yeah. And I think, you know, useful in terms of if we were able to risk profile, right? We don't need fancy genomic markers, or we maybe just ask, a lot of us have experiences with how we were reacting when we were exposed to hormonal contraceptives, or how we were doing postpartum. So maybe build in such information to guide clinical care would be interesting to study if it's possible, right? So I believe that women, and we have other data suggesting that women are quite, you know, capable of self-reporting hormone sensitivity, which is not maybe necessarily something that we should expect, but it is possible. So yeah, that is one direction.
Any other questions? If not, we'll proceed. Thank you so much again for a great presentation. And it's my pleasure to introduce the final speaker for this session, Dr. Benedetta Leuner from Ohio State University, who will be talking about moving beyond oral contraceptives and looking at the impacts on the brain. Adolescent brain, I should say. Adolescent brain.
Good afternoon, everyone. I'd like to first thank womenmind, CAMH, and of course, Lisa, for the invite to this important event. I'm really, truly honored to be here among this amazing group of scientists and advocates for women's mental health. And I'm excited to have this opportunity to share some of our recent work on hormonal contraceptives and the adolescent brain. Before I get started, I'm going to try this pointer quick. Okay. I have no conflicts of interest to declare. So as we've heard, hormonal contraceptives are among the most prescribed class of drugs currently used by approximately 150 million women worldwide, many of which will initiate use during adolescence. Approximately 1 in 5 teens, ages 13 to 18 years old, use hormonal contraceptives, and they do so for a variety of reasons, contraceptive reasons, as well as non-contraceptive therapeutic reasons, such as to reduce menstrual pain, for menstrual regulation, as well as a treatment for acne. So as you can see here, hormonal contraception comes in many forms. The form most often used by adolescents is oral contraception, or the pill. And this typically contains a synthetic estrogen, most often ethinyl estradiol, and that's combined with a synthetic progestin, of which there are many types, one of the more common given to adolescents being the second generation progestin, levonorgestrel. So these synthetic hormones and hormonal contraceptives are really potent analogs of endogenous estradiol and progesterone. And their primary mechanism of action is negative feedback regulation of the hypothalamic pituitary gonadal axis, which is shown here. So what these synthetic hormones and hormonal contraceptives do is bind to receptors in the hypothalamus to reduce secretion of gonadotropin-releasing hormone, or GnRH. This in turn suppresses or reduces the release of luteinizing hormone and follicle-stimulating hormone from the anterior pituitary. And then this in turn leads to a suppression of follicular development in the ovary and a decrease in ovarian production of estradiol and progesterone. And so in these ways, hormonal contraceptives produce a state of anovulation and acyclicity in the user. So hormonal contraceptives are generally considered safe and beneficial in many ways, but their use in adolescence has emerged as a potentially important risk factor for depression. Several large-scale studies have found that compared to non-users or users that start in adulthood, adolescent users of hormonal contraception have a higher rate of depression and antidepressant use, as well as higher relative risk for suicide. In addition, adolescent hormonal contraceptive use has been shown to predict future vulnerability to depression in adulthood, and this is even after controlling for concurrent use, pointing to possible long-term effects. From a mechanistic standpoint, the few neuroimaging studies that have included adolescent populations have found structural and functional differences in the brains of those who begin taking hormonal contraceptives during adolescence that are not observed in those who begin taking these drugs during adulthood. And so collectively, what this suggests is that adolescence may be a unique period of vulnerability for users of hormonal contraception. And the reason adolescence may be a unique period of vulnerability is because the brain is still maturing. Adolescence is widely regarded to be a critical period of hormone-mediated brain development, and this continued maturation of the adolescent brain is thought to make it particularly susceptible to perturbations, which then increase risk for depression. And this might be especially true for the prefrontal cortex. So the prefrontal cortex, or the rodent homologue called the medial prefrontal cortex, is one of the last brain regions to develop, and proper development of this region is necessary for many behaviors which mature during adolescence and which are known to be impacted in depression, like mood regulation, impulse control, and executive functioning, among others. We know from human work and rodent work that development of the prefrontal cortex is shaped by a variety of processes, such as synaptic pruning, increased myelination, refinement of excitatory inhibitory balance, as well as dopamine innervation that we heard about earlier today. Many of these processes contributing to maturation of the prefrontal cortex have been shown to be driven, at least in part, by ovarian hormones. And so given all of this, a central question our work seeks to address is how might disruptions to the hormonal milieu associated with adolescent use of hormonal contraceptives impact the development of the prefrontal cortex. So one approach to addressing this would be to compare adolescent users of hormonal contraception to non-users who are naturally cycling. But this can often be complicated by individual differences in factors like experience and genetics, the specific formulation of hormonal contraception, the dosage, the age of onset, the duration of use. And while it's difficult, if not impossible, to ethically and effectively manipulate and control these variables in people, we can manipulate and control these hypothesized sources of between user heterogeneity in animal models. So animal models also give us access to a wider range of experimental methods that provide information about the neurobiological effects of hormonal contraceptives at a cellular and molecular level of analysis that's not always feasible in humans. And so while certainly not a replacement for human studies, they are an important way to complement and inform human work. And so to study the effects of hormonal contraceptives on the adolescent prefrontal cortex, we developed a rodent model of adolescent hormonal contraceptive administration. And this was work led by a grad student in the lab, Rachel Gilfarb, who collected much of the data I'm going to show today. So in Rachel's studies, our rats are born on postnatal day 0. We wean them at postnatal day 22. And then beginning around postnatal day 30, not around, on postnatal day 30, we monitor for vaginal openings, which is a proxy indicator of pubertal onset in female rodents. So we confirmed that all of our experimental rats underwent vaginal opening by postnatal day 35, at which point they began receiving daily subcutaneous injections of either a vehicle or hormonal contraception. And this consisted of the combination I mentioned earlier, and which you've heard about in the other talks, ethinyl estradiol and levonorgestrel. So we treated these animals daily for 3 weeks during this time. We also performed vaginal lavage to monitor estrus cycling. And then at the end of this 3-week treatment period, we collected blood and brains for analysis. And so as a way to first validate that our treatment paradigm was effective, we assessed estrus cycling and found a suppression with hormonal contraceptives. So here you can see in our vehicle-treated animals, they were largely cycling and fluctuating from stages of diestrus to proestrus and estrus. Our hormonal contraceptive-treated animals, however, were largely acyclic and in a state of persistent diestrus. As further validation that our treatment was effective, we also did an ELISA for luteinizing hormone and found that hormonal contraceptives suppressed luteinizing hormone, levels of which were undetectable in our contraceptive-treated animals. And so when taken together with the estrus cycle data, indicates a suppression of the HPG axis, which was what we had hoped for and what we had expected. This is the problem slide. Okay. We next determined the extent to which hormonal contraceptives could suppress endogenous steroid hormones as well as their effects on the neuroactive progesterone metabolite allopregnanolone. And here we used a highly sensitive technique called liquid chromatography mass spectrometry. We did this with the help of the Endocrine Technologies Core at Oregon Health Sciences University. And what we found in the blood or the serum was that hormonal contraceptives suppressed circulating estradiol, testosterone, and allopregnanolone. We also looked in the brain, and although the effects weren't as widespread, with only a decrease in allopregnanolone being seen in our hormonal contraceptive treated group, these data are admittedly very preliminary. We need to add more animals to fill in our groups before we can make any definitive conclusions, but we think they're promising nonetheless and appear to be trending in the expected direction. Problem slide. Right, there we go. All right. We also used LCMS to measure concentrations of the synthetic hormones. And we found that both ethinyl estradiol and levonorgestrel were present not only in the blood, but also within the brain. And this has important mechanistic implications because it suggests that hormonal contraceptives could possibly be exerting direct effects locally within the brain and not just through a suppression of peripheral endogenous hormones. So once we had validation that our paradigm was effective, we then turned our attention to the prefrontal cortex. And using a nanostring method, we looked at the effects of hormonal contraceptives on a broad panel of genes, a number of which have been implicated in neurodevelopment. And this was work done with the help of a postdoc in my collaborator's lab, Dr. Marissa Smale, and the data are shown here. So what you can see in blue are genes that were upregulated by hormonal contraceptives, in red, those that were downregulated. And overall, we found that a variety of genes were impacted, including a number of genes related to synapses, glia, monoamine signaling, and hormonal signaling. The category, however, where we saw the most changes was in neuroamine signaling. So one of the most important mediators of neuroimmune signaling in the brain are microglia, as we heard Georgia talk about this morning. And so given our nanostring data, we were interested in what might be happening to microglia in our hormone-treated rats. So just to remind you really quickly, microglia are the resident innate immune cells of the brain. They're pictured here, labeled with the marker IBA1. And they play a well-documented role in many pathological conditions and the brain's response to injury or insult. However, it's also become clear in recent years that microglia serve important functions in the healthy brain. And one such function is to shape brain development and to regulate neurodevelopmental processes. And the way they do so is via secreted factors like cytokines or through the process of phagocytosis, which is the engulfment and digestion process. Importantly, microglia also express steroid hormone receptors. And so maybe it's not too surprising that we found that they were sensitive to hormonal contraceptives. So here you can see immunolabeling for that marker, IBA1. And when we counted the number of IBA1 positive cells, we found a reduction in our hormone-treated animals. Along with this reduction in microglia number, we also found that microglia morphology was changed. And this was work done by a talented undergrad in the lab, Sanjana Ranade. And what Sanjana found was that microglia of rats treated with hormonal contraceptives had a larger soma size and reduced branching complexity. Now, this is a phenotype that's typically associated in adults with microglial reactivity and microglia that are engaged in more inflammatory signaling. But it's important to recognize that microglia morphology is not always the best indicator of their function, and that's especially true in the developing brain. So in the developing brain, microglia tend to have these enlarged cell bodies and fewer branches, although they're not activated in the same way that microglia with this morphology in the adult brain are in response to pathology or insult. Developing microglia also differ from microglia in the healthy adult brain, which tend to have smaller cell bodies and highly ramified processes. And so what our data might suggest is that hormonal contraceptives are not necessarily leading to more microglial activation, but they may be affecting the development of microglia into a more mature ramified phenotype. And this is a working hypothesis. We still need to test this hypothesis, but that's what we're working with now. Okay. So these perturbations to microglia resulting from adolescent exposure to hormonal contraceptives could have consequences for the developmental processes they regulate. And two of the main ones are synaptic pruning, pruning of excitatory synapses specifically, and myelination. And so we looked at markers related to these processes. And what our data suggests so far is no significant effect of hormonal contraceptives on excitatory synapses, at least as measured with this one marker, PSD95. However, our data do suggest that myelination might be impacted. So specifically what we see is an increase in staining for the myelin marker, myelin basic protein in our hormone contraceptive treated animals, as well as an increase in the number of oligodendrocytes, which are the cells that produce myelin, labeled here with a marker called CC1. So now we're trying to put it all together, trying to determine if maybe microglia might be mediating these changes either through secreted factors or changes to phagocytic function, And although this is still an open question, I think our data so far do suggest that the prefrontal cortex is being impacted. And this likely has implications for prefrontal cortex function and maybe behaviors of relevance to depression. And so we've also been interested in looking at the behavioral impact of hormonal contraceptives during adolescence. And for these studies, we followed the same exact paradigm that I mentioned earlier, except now animals underwent behavioral testing on a variety of mood-related behavioral tasks, specifically the forced swim test, novelty-induced hypophagia, and elevated plasmase. Interestingly, we didn't see any effects of hormonal contraceptives on coping behavior in the forced swim test, which is kind of a widely used test for depressive-like behavior in rodents. Other behavioral tests, however, were sensitive to hormonal contraceptives, including behavior in the novelty-induced hypophagia paradigm. So just to kind of familiarize you with this paradigm, animals are exposed to a cereal treat in their home cage. After 3 days of habituation, we do a home cage assessment where they get the treat, and we measure the latency for them to approach and consume that treat. And then on the last day, we do the same procedure, except now it's done in a novel environment that's made aversive with a wire bottom and a bright light. So typically, although you find that animals are really motivated to consume their treat in the home cage, presentation of that treat in a novel environment delays consumption of the treat. And that's what we see in our vehicle-treated animals, a longer latency to consume the reward in the novel cage compared to the home cage. Our hormonally contraceptive-treated animals do not show this effect at all. Their latency to consume the treat in the novel cage is the same as in the home cage. And so there's, there's a couple of ways we can interpret these data. One is that hormonal contraceptives might be decreasing anxiety-like behavior. Another possible interpretation is that they could be impairing risk assessment behavior in a novel environment, and this could potentially reflect impaired behavioral maturation in our hormone-treated animals. We also tested rats in the elevated plasmase. We've heard about this task in other talks. This is a raised platform with 2 arms that are open, 2 arms enclosed by walls. Rats have a tendency to stay in the enclosed spaces due to their unconditioned fear for open spaces and height. However, rats that have decreased anxiety or risk assessment enter the open arms more and spend more time in the open arms. And that's what we see in our hormone contraceptive treated animals, more time in the open arms. The hormone contraceptive treated animals also engaged or displayed less what are called stretch attend postures. So this is a posture where the animal is in the closed arm, and then they kind of, I'm gonna like act it out for you. They kind of stretch their bodies out and kind of peek into the open arm in a low posture. And this is widely regarded to be a measure of risk assessment. And so, like novelty-induced hypophagia, this tendency for our hormonally contraceptive treated animals to display less risk assessment might reflect impaired behavioral maturation, maybe related to the myelin changes that I mentioned earlier. Another point maybe worth considering is that decreased risk assessment could be indicative of impulsivity. So impulsivity is the tendency to react quickly without considering consequences, and it can be a feature present in depression and other psychiatric conditions in which prefrontal cortex function is disrupted or adolescent maturation is impaired. Okay, so there's 0 minutes left. So to conclude, we've validated a model of hormonal contraceptive use in rats. Hormonal contraceptives are detectable in the brain, and we find that administration during adolescence impairs or impacts, I should say, PFC, white matter, the neuroimmune system, and behavior. Despite these findings, there are lots of open questions that are left. One is, what's driving these changes in the brain? Is it suppression of peripheral hormones? Is it direct actions of these exogenous hormones? Is it some off-target effect, such as the HPA axis, which we've heard about? Is the synthetic estrogen or the synthetic progestin driving these effects? And really importantly, do these changes persist into adulthood? Are they long-lasting? So before I end, I just wanted to mention that hormonal contraceptives have been around for over 60 years, but we're now just beginning to understand their effects on the brain, specifically the adolescent brain. But it's important to have these data to allow women to make informed decisions concerning their short-term and long-term health. I'd like to thank my collaborator, Katie Lenz, the trainees in my lab who helped with this work, the Endocrine Technologies Corps for their help with the LCMS analysis, our funding from the NICHD. Real quick, I'd also like to draw your attention to this special issue of Hormones and Behavior that I'm guest editing with Adrienne Beltz. So if you have any new cool data on hormonal contraceptives, please consider contributing. And then I'd also like to invite everyone to join us for the annual Society for Behavioral Neuroendocrinology meeting in Columbus, Ohio this summer that I am co-hosting with my wonderful colleagues, Dr. Erica Glasper and Katie Lenz. So I'm done, and I'd be happy to take any questions.
I think we have time for one question right over here. Oh, you have two. Can I do two questions? Two questions. Okay, we'll do two questions.
Hi, excellent presentation, and I really truly think that we should move away from the ethinyl estradiol-based drugs as a first-line option in the adolescents. But what would be really important for me as a clinician is to provide alternative, because it's not going to help if we just say that wait until you're 18. So are you planning to rerun these studies with progesterone only to, yeah, that would be really helpful.
The original design for these studies all included a progestin-only group that only got the LNG to kind of parse out the effects of the different components. We didn't have funding at the time, so we had to drop that group from our initial analysis. But moving forward, that is a really great question. Looking at progestin only, looking at other progestins, other formulations. I mean, this is a big task, right? There are many. And so it's big, but it's important. Ooh, geez.
Great. We have one more question over here. Yeah.
Thank you so much. So I have a little, I will try to articulate myself. So the question is that you said, are we suppressing endogenous hormones? Or it's really these exogenous, like synthetic hormones that are doing something. But I also am wondering, what are we measuring when we measure? Because we, in our post-mortem cohorts, had some young women that had very high level of estradiol, and we were very confused. We went and then we checked and we found that they were using oral contraceptives. So I think it's a really multifaceted question in terms of what are we measuring? When we measure with mass spec estradiol, is this endogenous or exogenous? And also, what are you seeing in terms of what's happening in the brain? Do you think this is just the ovarian hormones, or it's also centrally synthesized estrogen that are being affected by this? So I know you have to speculate, but it's my question because you're studying this. It's just a speculation. What do you think?
In terms of the high estradiol in your samples that were users of hormonal contraception, I think it might be important to know what type of hormonal contraception they are. I don't think, and the clinical folks can correct me if I'm wrong, I don't think all lead to that HPG axis suppression. So that's one possibility. Ethinyl estradiol, yeah. Then I don't know. Maybe compensatory mechanisms. Yeah, that's a good question. What was the other part?
About the centrally synthesized.
Oh, yes.
Because there are studies showing that the peripheral and central synthesized as well are also in sync. So do you think they're affected?
it's hard to tell from our data so far. You know, I think these synthetic hormones are getting into the brain. They're very potent analogs. They, you know, potently activate receptors within the brain, so they could be having just kind of ignore the central changes in estradiol by itself. They could just be acting.
No, no, for
Yeah,
sure.
yeah,
But
yeah.
what do you think about gabapentin or something like that? Like something that is central. Right?
Yeah.
No idea, right?
No idea yet. No, but it's an important question to look at those enzymes and yeah.
Great. I know there's more questions, so hopefully that can happen over the break, but thank you. Thank you again, Dr. Leuner, for your presentation. That wraps up this session. We had great 4 talks here, really building on one another. And again, round of applause for all 4 presenters again.